Welcome to our lecture on acute coronary syndromes, or ACS. Today, we are going to explore the critical goals for patient care, the underlying pathophysiology of the disease, and how to navigate the ACS algorithm to save lives. To understand the urgency of ACS, we have to look at the statistics. Half of the patients who die from acute coronary syndromes do so before they even reach the hospital. The precipitating rhythm in most of these out-of-hospital deaths is ventricular fibrillation, or pulseless ventricular tachycardia. And crucially, this is most likely to develop within the first 4 hours of symptom onset, which is why rapid community response and early defibrillation are absolutely vital. When a patient presents with ACS, what exactly are we trying to achieve? Our primary goals are fourfold. First, we must rapidly identify patients with a stem segment elevation myocardial infarction, or STEMI, and triage them for early reperfusion. Second, we need to relieve their ischemic chest discomfort. Third, we aim to prevent major adverse cardiac events, known as MACE. And finally, we must be ready to treat acute life-threatening complications, like arrhythmias. For STEMI patients, time is muscle. Reperfusion therapy is how we open an occluded coronary artery, and we have two main ways to do this. The mechanical route is percutaneous coronary intervention, or PCI, where a balloon or stent is placed directly into the artery in the cath lab. The pharmacological route uses fibrinolytics, commonly known as clot busters, to dissolve the blockage. Let's look at what is actually happening inside the heart. Patients with coronary atherosclerosis develop varying degrees of artery occlusion. It starts with early plaque formation, which grows into a significant, unstable plaque. The critical moment in ACS is when this unstable plaque ruptures, causing a thrombus, or blood clot, to form. This rupture can release microemboli and severely restrict blood flow. Once that plaque ruptures, the patient enters the spectrum of acute coronary syndromes. If the thrombus partially occludes the vessel, it presents as non-ST segment elevation ACS. However, if that thrombus grows to completely occlude the coronary artery, it becomes a STEMI, a massive heart attack requiring immediate reperfusion. Sudden cardiac death can occur at any point in this spectrum. Recognizing the symptoms early is our first line of defense. The most common symptom of myocardial ischemia is retrosternal chest discomfort. Notice I said discomfort, not necessarily pain. Patients often describe it as a pressure, tightness, or squeezing in the center of the chest. This discomfort can radiate to the shoulders, neck, arms, jaw, or back, and is frequently accompanied by sweating, nausea, or sudden shortness of breath. While we must act quickly on suspected ACS, we also have to keep our differential diagnosis broad. Not all chest pain is a heart attack. You must consider potentially lethal mimics. Aortic dissection, acute pulmonary embolism, pericardial effusion with tamponade, and tension pneumothorax can all present with severe acute chest discomfort and require entirely different immediate treatments. Now let's walk through the ACS algorithm, starting in the out-of-hospital environment. When EMS encounters a patient with symptoms suggestive of ischemia, they immediately support the ABCs and prepare for potential CPR or defibrillation. They administer oxygen, aspirin, nitroglycerin, and morphine if needed. Crucially, they obtain a 12-lead ECG. If it shows a STEMI, EMS must notify the receiving hospital immediately so the cath lab can be mobilized before the patient even arrives. Once the patient arrives at the emergency department, the clock is ticking. The immediate ED assessment must be completed within 10 minutes of arrival. The team will check vitals, establish IV access, and perform a targeted history and physical. They will also draw blood for initial cardiac markers and order a portable chest X-ray to be done within 30 minutes. The most critical juncture in the ED is step 4, the interpretation of the 12-lead ECG. This categorizes the patient into one of 3 treatment pathways. If there is ST elevation, or a new left bundle branch block, it's a STEMI. If there is ST depression, or a dynamic T-wave inversion, it's high-risk non-ST elevation ACS. Finally, if the ECG is normal or non-diagnostic, the patient falls into the low or intermediate risk category. I want to highlight a vital consideration for STEMI patients. The ECG is the absolute center of your initial risk and treatment stratification. While we do draw blood for cardiac markers like troponins, you do not need evidence of elevated cardiac markers to make the decision to administer fibrinolytics or perform a PCI. Waiting for lab results delays reperfusion, and delaying reperfusion kills heart muscle. Treat the ECG. To wrap up, successfully managing acute coronary syndromes requires a coordinated system of care. It starts with recognizing symptoms and ruling out lethal mimics. EMS plays a vital role by getting an early ECG and notifying the hospital. Remember, the 12-lead ECG drives your entire triage pathway. For a STEMI, rapid reperfusion is the ultimate goal, and because time is muscle, never delay life-saving treatment while waiting for cardiac markers. Thank you for joining this lecture.